We know that we classify oxygenation as 80 to 100 being normal, 60 to 79 being mild, 40 to 59 being moderate, less than 40 we're considering severe. When we use oxygen therapy, we actually kind of need to readjust those terminology. So if the PaCO₂ is still below 80, it's uncorrected hypoxemia of a mild, moderate, or severe nature. In other words, we're attempting to correct it. The PaCO₂ should be higher, but it's not. If we've corrected the PaCO₂ back to within a normal range, between 80 and 100, we're going to call that corrected hypoxemia. And finally, we're going to see a situation where the PaCO₂ is higher than 100, so it's elevated, it's hyperoxemia, but basically we've overcorrected it, or we're going to call excessively corrected hypoxemia. The example here is a PaCO₂ of 40, a PaCO₂ on 40% oxygen of 138.4. I know that the maximum, or the potential maximum, rough rule of thumb, 5 times the FiO2 will tell me what the theoretical ceiling is, 200. And this PaCO₂ is greater than 100, but less than the possible. So we're basically going to call this excessively corrected hypoxemia. Does that make sense?
Where did you get the 5 from, the 40 times 5?
That's the rule. 5 times the FiO2 is the theoretical maximum you could possibly have. If you go back somewhere in module C, pardon me?
If it's more than 1.
More than.
No, if it's more.
If your PaCO₂ in this instance is greater than 200, you got an error.
Okay.
They're probably not on 40%. Okay. Or you got an air bubble. Okay?
And if it's corrected, it's between 80 and 100, you said?
That's correct. That's called corrected hypoxemia. In other words, if I took the oxygen away, they would be hypoxemic. But because they have them on oxygen, pardon me?
What if they're not on oxygen? That's just...
Well, that's with oxygen therapy.
I started listening like 2 minutes in.
Wow! Hey, at least she's honest. Daner.
So if you're like an older patient though, like, and normally their PaCO₂ would be a little bit lower, and they're still on like say 40%, and they're still satting like 75. I mean,
They're satting 75.
Like I mean not 75.
Their PaCO₂ is 75.
Yeah.
Okay.
Would that be? Like,
If they're on oxygen, that'd be uncorrected hypoxemia.
okay. So you'd expect it to be higher.
Yeah. Yeah. Their normal may be lower, but still, when you put them on oxygen, it should boost it up. All right, let's talk about PaCO₂ and some kind of problems that you might see on a theoretical exam. Rick, we don't have this. Yeah, you do. It's in Module G. If you look at Bullet 21 in the textual component of it. Keep going, Erica. Keep going. Keep going, Erica. Keep going. 21. So part of this exercise is, first of all, interpreting the blood gas that you end up having, and then evaluating whether or not the CO2 needs to be corrected. We're not going to correct for CO2 if the respiratory system is compensating for a metabolic problem. If I have a metabolic alkalemia and I have hypercapnia secondary to a compensatory mechanism, I'm not going to fix the CO2. I'm going to leave it alone. I'm not going to fix the CO2 if the pH is normal. Okay? That's a fully compensated respiratory acidosis. I'm not going to screw with it. I don't try to correct a low PaCO2 if I have a head injury and it's in the situation where I'm attempting to hyperventilate the patient. If you remember, as you hyperventilate, as you create hypocapnia, you actually reduce cerebral blood flow. It's one of the treatments, in theory at least, for head injury. Truly, we should not be doing that without an ICP monitor in, and really a sensor in the brain tissue itself that is measuring oxygenation. So, if you will, a SAT monitor embedded into the cerebral cortex. Because you're shutting down blood flow. Well, that could be a bad thing. I understand I want to shut down blood flow to reduce swelling, but I'm shutting down blood flow and to reduce oxygen delivery. It's got a balance between the two. Okay. Is the patient hyperventilating because of hypoxemia or hypoxia? If that's the case, then it fixed the oxygenation problem, not the CO2 problem. And the real question is, how much should the PaCO₂ be corrected to? A lot of times, we don't want to go back to 40. That's not the proper thing to do if somebody's got a chronic hypercapnia. Somebody who's in chronic respiratory failure, their normal CO2 is going to be higher than that. So what value do we correct to? Well, it's very simple. You divide the bicarbonate by 0.6. So find out what my bicarbonate is, divide by 0.6, that's the PaCO₂ I want to correct to. Where that 0.6 comes from, I go through in the text. You can just say divide by 0.6. Makes life a whole lot easier. But it has to do with that Henderson-Hasselbalch equation, the ratio of bicarbonate to carbonic acid, and that 20-to-1 ratio, kind of an approach. Okay. So let's look at some. So how am I? I had the slide in there. Hold on. How am I going to accomplish correcting the PaCO₂? Oh, okay. If they're on a ventilator, it's pretty easy. We're going to basically either adjust the minute ventilation, the respiratory rate, or the tidal volume. And what I have here is my actual PaCO₂ times my actual minute volume that was measured at the time of that blood gas being drawn. My desired PaCO₂, which is bicarb divided by 0.6, times my desired minute volume. So this is what I'm going to be solving for, is this desired minute ventilation. I can substitute in, instead of minute ventilation, I can substitute in tidal volume, or I can substitute in respiratory rate. It's really up to you. Well, no, it's not. It's up to whatever I ask you. Okay? Some ventilators, especially older ventilators, worked on minute ventilation. We actually set a minute volume and a respiratory rate. The tidal volume was determined from them. Obviously, we set tidal volume and we set rate to be able to make these adjustments. So far, so good. I haven't told you any lies. Well. So, given a fixed alveolar minute ventilation of 4 liters per minute, calculate the PaCO₂ when the CO2 production is 300 milliliters per minute. 100 milliliters. So how do I solve for PaCO₂? Right? So plugging in my numbers, I end up having 300 times 0.863. 4 divided by 4. I don't have my calculator, so I'll use my phone to phone home. 300 times 0.863, 258.9 divided by 4 is 64.725. So I would have a PaCO₂ of roughly 65 torr. You think you'll see a problem like that? You betcha. Does that make sense? Everybody see where I got those numbers from? Now, I could give you a CO2 and a CO2 production, and you got to tell me the alveolar minute ventilation. You can go, I give you 2 of the 3, and you solve for the third. Okay. Given a tidal volume of 400, a physiological dead space of 200, and a frequency of 16, calculate the alveolar minute ventilation. Well, this is easy, actually. I'm really being too easy on you, because we know that this is equal to 400 minus 200 times 16. 200 times 16 is 3.2 liters per minute. Okay. Now, could I give you a VD-VT ratio? Could I give you a PaCO₂ and PeCO₂ to make you calculate the VDT ratio to multiply it times the tidal volume to get what your dead space volume is? Could I give you a person's height and gender so you can figure out anatomic dead space? Yes, 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 yes. Of course I will. Okay. So here's the question. You're ventilating a patient in the assist control mode with a tidal volume of 600, rate of 12, FiO2 of 50%, peak flow rate of 60 liters per minute. These are my blood gases. What ventilator change would you recommend? And feel free to use your clickers that nobody's using. Well, one person. And the answer is maintain current settings. Why? Okay. Let's take a look at what CO2 I would want to correct to. CO2 is at 60. So there really is not a need to make any changes related to that. Plus, I have a normal pH. If anything, I might consider dropping his FiO2, because that PO2 is a little bit high for a COPD patient. Got the gist? Say who? That's normal for him or her. Okay, a patient with respiratory acidosis on mechanical ventilator support. He's 6'2" and he weighs 190. The exhale tidal volume is 400 milliliters and his frequency is 10. The patient is on controlled volume ventilation. He's being pharmacologically controlled. PCO2 is 60 with a pH of 7.33. The desired PCO2 is 40. What ventilator change must be made to decrease the PCO2? And the physician asks you to use tidal volume as your mechanism. Okay, so what do I need to change the tidal volume to be able to accomplish this? You sure do. So, actual PCO2 times actual tidal volume is equal to desired PCO2 times desired tidal volume. Rearranging my desired tidal volume then is equal to my actual PCO2 times my actual tidal volume divided by my desired PCO2. Just plug in numbers. Actual PCO2 we had was 60. Actual tidal volume was 400. Desired PCO2 was 40. So 60 times 400, 24,000, divided by 40, 600. Okay. Now again, this assumes that I have a controlled patient where they're not triggering, etc., etc., etc. But that's the way the problem would be set up. How about this one? What do you notice in this question is perhaps a key point I want to keep in mind? They're controlled, okay. What else? 5'2" is not short. Casey, is 5'2" short? No. 5'2" is a giant compared to Casey. What else? I'm sorry? Okay. What's causing the acidosis? Do you need one?
No, but you're asking what causes it.
Yeah, I'm asking you.
Probably the CO2.
Probably the CO2. Okay. So you think I want to so if I correct the PCO2, will I correct the pH? Probably. My first gut is, yeah, that's about a 18 torr change from normal. So it's 1.8. So you drop for every 10, you drop 0.08. So it's almost 0.1. Call it 0.15. 7.4 minus 0.15 is 7.25. I'm close enough. If you didn't follow exactly where I got that from, it goes back to that table we had the very first day, where we were saying for every 10 torr change in PCO2, there's a 0.08 change in pH. So pretty much all of the problem with the pH being dropped is due to the CO2. What else? What does the next sentence say? Does anybody have a problem with this?
Yes.
Thank you. Too high. So if I'm going to correct this CO2, what are the ways I can do it? How do you correct PCO2, guys? Going to have to change the rate. I can't screw with the tidal volume. I can't make the tidal volume bigger. Plateau pressure is already 30. Okay? So I've optimized tidal volume. Now I got to look to my rate to do something different. Fair deal? So how do I do this? Well, same way. Desired PCO2, actual PCO2 times actual frequency is equal to desired PCO2 times desired frequency. And I'm telling you that I want to go to a PCO2 of 40. I give you an ideal body weight there, and if you were to figure it out, this tidal volume is a little bit large. I certainly don't want to go up on it. If anything, I need to go down. So my actual PCO2 was 58 times an actual frequency of 7. Right there, it should point out. I want to drop it to 40 times desired frequency. So 58 times 7 divided by 40. Frequency. So 58 times 7, 406 divided by 40. You want to get rate of 10.15 or figure 11 because you want to go up. It's multiple choice, guys. Okay, you get the gist? So clinically, when you walk into and you got a patient whose acidosis needs to be corrected from a respiratory standpoint, you should be able to say, well, I want to drop my rate to this value. And not just use the swag method. Well, let's go down by 2. Well, let's go up by 4. How do you know it's 4? Yeah. Got a blood gas, I'm going to make a second change. Liz.
Would you ever want to decrease the tidal volume and then
Theoretically, you could, yeah. You could put the tidal volume to a lower value and then increase the rate also even further.
especially when you're doing ideal body weight?
Yeah, yeah. How about another one? Patient has the blood gas is shown here. He's in the control mode. No spontaneous breathing. Tidal volume 700, frequency of 18. Doctor asks you to correct the pH because we're a little bit alkalotic. Would you not agree that that's the worst of the problems? Yeah. What's causing the alkalosis? Yeah, it's a respiratory problem, right? So where do I want to put my rate to or my tidal volume to be able to get to that point? Well, let's figure it out. Let's say that I wanted to utilize this. We'll pick the rate as an arbitrary. So my actual PaCO₂ is 20. Actual frequency is 18. Desired PaCO₂, I'm going to go to 40. Technically, what should I do to determine desired PaCO₂? Thank you. So it should be 22 divided by 0.6. Let's see what that comes up to be. 37. So let's make this 37, just for giggles. That'll put us back to a 7.4 pH. So 20 times 18 if I knew how to type in things, it'd be wonderful. Really? That's 360 divided by 37. Equal to 9.73. So I can actually go down to a frequency of 10 and still be adequate. Looking at these blood gases, I don't think I would have picked 10 as my rate. I would have been, let's put them down to 14. Let's put them down to 12. 4 months later, you're finally at the place you're supposed to be. Or here, well, one fell swoop, I'm there. Okay, it's all mathematical. The body actually works pretty cool. Okay, I'm ventilating a patient on the Servo ventilator, the old Servo series. You set minute ventilation. So this is one where I'm not worrying so much about changing tidal volume or rate. I'm going to use minute ventilation as an overall value. How would you change the ventilator? Meaning, what minute ventilation would you secure to change to get to a normal pH? What do you think? Desired. No, did it again. I am just losing my mind. Actual PaCO₂ times actual VE divided by desired PaCO₂. Give me desired VE. What's the first step? Besides dropping the class. What your CO2 should be, and so I'm not correcting to 40. I'm only going to correct to 30. What would happen if I were to correct this to a normal CO2? It won't be acidotic. It'll be alkalotic. Because I would correct too far.
You're alkalotic right now.
But they would still be alkalotic. Because I'd be blowing off more CO2 to get back to that 40. Okay, let me go ahead and and do this one then. So we said actual, there I did it right, PCO2 times actual minute volume, actual, so I have an actual 24 times the minute ventilation of 12 divided, what did I say it was? 30. So 24 times 12 is 288 divided by 30 is 9.6. So my minute ventilation needs to be changed to 9.6 liters per minute. And we would probably do it by leaving the tidal volume the same, just changing the rate.
Can you go back to the question, please?
You have it in your book.
No, I was just,
Yeah, no, it's different.
7 and 7 is
Okay. Okay. What do you need? Well, why don't
I'm so confused by the fact that you said if we go to 40, we're going to do an overshoot, and it's still going to be off a lot. How is that possible? You're retaining more CO2, aren't you?
Yes, you're right. I misspoke. You're not correcting far enough.
So then they would become acidotic?
They would be acidotic. You wouldn't fully correct them back to 7.4. Two more. Is this making a little bit of sense?
Yeah, a little bit.
Do you want me to just stop?
Yeah, no.
You're called to the ER for a caring of a closed head patient, closed head injury. He's on mechanical ventilator settings that you see there. Blood gas shows those following results. His ICP is elevated and physician wishes to hyperventilate the patient to a PCO2 of 30 to decrease the ICP. How are we going to accomplish this? Same thing, right? So it's my actual, thank you very much, PCO2 times actual. Let's say we're going to use the rate. Desired. So my actual PCO2 was 42 times an actual frequency of 12, and my desired is 30. Okay? Just do the math at that point, just plug in the numbers. But the key part is you need to make sure that you get back to the desired PCO2 that you want, not to 40. And I guarantee somebody's going to go back to 40. Yes, ma'am?
So how do you decide whether you want to change the rate or the title?
It's
I mean, sometimes it's pretty
I'll,
obvious.
yeah,
but
I will tell you that the answer will give you the clue. In other words, I wouldn't put both options on there.
Well, in clinical setting, like I want to.
What do you normally change? Once you set a tidal volume, you rarely change that tidal volume unless you're going to a lung protective strategy. We almost always use respiratory rate as the controller. What's that? No?
What was that over there?
Let's move on to our last problem.
Is that why all those patients are very loud?
Got a minute ventilation of 10 liters per minute. There's my blood gases. I want to correct the pH. Okay. Why am I not worried about correcting the PO2? That's the cause of the hypoxemia. Yeah, correct the PCO2, you'll correct the PO2. Okay. So what are we going to do?
You want to calculate what you want there to.
Very good. First step. Bicarb divided by 0.6. Bicarb on that value there was 30. Was it 50? No, it's 30.
The answer is 50, sorry. 30 divided by 250.
So this is my desired PaCO₂. So actual PaCO₂ times desired
Every time.
every time. Minute ventilation, because that's all I'm given. Actual PaCO₂ was 70 times actual minute ventilation of 10 divided by 50. 700 divided by 50, 14. So I would need to change my minute ventilation from 10 to 14 in whatever fashion I end up doing that. But that's the key step. All right? And I think I'll stop there.